Welcome everybody. This is the webinar on the value of contrast-enhanced ultrasound in the diagnosis of focal liver lesions. I'm very pleased to announce that this evening we've got a full panel of speakers from 3 different countries, from the Netherlands, from myself from the United Kingdom, and a lecturer from Milan in Italy. The theme of the evening is to look at the usefulness of contrast-enhanced ultrasound in assessing focal liver lesions. And our first speaker will be Professor Ken Redekop, who's the Associate Professor of Health Technology and Assessment of Erasmus University in Rotterdam, the Netherlands. I will follow on, and the topic Professor Redekop is going to talk about is the evidence and cost-effectiveness of contrast-enhanced ultrasound and the NICE study results. I will follow on, and I'm a consultant radiologist and professor of imaging sciences at King's College in London. And I will talk about the EFSM guidelines and the recommendations on the clinical practice of contrast-enhanced ultrasound. And Dr. Marco Ciceri will conclude the session and talk about the clinical development of contrast agents, its multiple indications, and a retrospective analysis of safety and efficacy data. The question and answers program will be on throughout the webinar. And if you type in your questions, I'll endeavor to answer them as we're going along. But there will be time at the end of the 3 lectures to actually interact and ask questions directly to the speakers. And we will all be available to answer these questions for you. This webinar will be recorded and you'll be able to review this at a later date. And you'll also receive an email with a link to the recording in the next few days. So without any further ado, I call on Professor Ken Redekop to start this session with his lecture on the evidence of cost effectiveness and the NICE study results. Ken.
Yes, thank you, Paul. I would like to thank Abraco and Gianfranco and Jerome for inviting me to share with you the results of a study that we did a while ago for NICE in the UK, related to, as you can see, the evidence of cost effectiveness of contrast-enhanced ultrasound. And so I'm being mindful of the time, but I'm also wanted to sort of share with you the highlights, but also some of the details regarding the study, because it was an intriguing study in different ways, but I think you'll see that in a moment. So just a brief overview of what I'm going to be showing you. Just some steps in a cost-effective analysis, what it entails. So not all the details, but the parts that you should be aware of. The results, of course, of the study that we did, but some reflections as well. I'm actually going to show you the main messages, and the first of them being that cost-effectiveness is an important criteria in many jurisdictions, in many areas regarding decisions about reimbursement and implementation. Obviously not the only criterion. I mean, safety and effectiveness are 2 important criteria, but this is one that, of course, has gotten a lot of attention over the years, and which has meant that we've got to get a better understanding about how we actually define cost effectiveness. The second part represents the challenge that has been faced by all of us. How do you do a cost effective analysis of a diagnostic test? Because obviously the diagnostic test alone won't save lives, improve health, but really it has to be combined with other things, treatment decisions. And the last one is basically the takeaway that in our study we concluded that contrast and enhanced ultrasound for the characterization of incidentally detected focal liver lesions is cost effective versus contrast-enhanced CT and contrast-enhanced MRI. The study that I'm going to describe to you was published a while ago in 2013. Basically, it's a long report of the results. That includes not just the results, of course, but also the methodology. The NICE has a very strong tradition. It's widely respected for the detail in which the people who do these kinds of studies have to follow basically a very strong methodology, which has been, which at the time that we started was being applied to the areas of cost of diagnostic tests. So to put it into context here, The specific objective that we had was to compare the clinical and cost effectiveness of contrast-enhanced ultrasound using SonarView with contrast-enhanced CT and MRI for the assessment of adults with focal liver lesions in whom previous liver imaging had been inconclusive. And I don't know if you're familiar with the general principles of the PICO. The population in this case, as it should be obvious. And when it came to the comparators that we would be assessing, we were comparing a SonarView of contrast-enhanced ultrasound with CT and in other analyses with MRI. The standard outcome that we use in these kinds of studies is basically healthy life years, or which is basically termed quality adjusted life years, qualities in other words. And that basically means that, long life is not necessarily a happy life or not necessarily a healthy life. And really what we should be trying to achieve is health and not simply a longer life. For this particular study, we actually chose, or there were 3 specific applications chosen, not by us, but actually by a group in NICE, who at the start identified the different ways in which contrast and enhanced ultrasound could be used. And you can see that there were 3 very different applications that we had to assess. The third one was the one that I was involved in particular, and that's what I want to highlight with you. But I'll say basically that the methods that we applied were the same for all 3. As I said before, then the NICE has a very strong tradition of applying the same methodology in a very systematic manner, so that everybody understands exactly what was done and everybody can review what was done. So the documentation, of course, is an essential element in good research. And they say basically they want to show people this is what we found and this is what we conclude. The starting point you can see on the left-hand side means that, as you know, with any kind of test, you can apply it in many different ways. But if you really want to identify what's worth doing, you have to identify how it will be used in practice. And basically, that's what we're talking about with the scope. The scope basically I already showed you, except for the care pathway. The second part, it looks at the basically the literature, what's been published, what's available on the internet, but in other kinds of trusted sources. The third one is the modeling, basically the calculations, so the modeling, the preparation, and the 3 and 4, the preparation for the models and the analyses, and followed by some kinds of presentation of results, which should result in some kind of decision about reimbursement. Basically, it will always be involved in some result. Sometimes there will be inconclusive results regarding the analysis, but some decision has to be made at the end of the day. I'll give you some idea of how rigorous this study is. So let's just look at the literature review, and you'll see a whole list of different kinds of databases, a whole list of websites, a whole list of different kinds of conference abstracts that were reviewed. So basically, it's extensive. Essentially, if something's out there, it should be found using this kind of a method. And in fact, in using this method, about 850 publications and titles and abstracts were identified using these kinds of methods. But then if you filter through the different studies and look at it one by one, usually with the second reviewer, you'll conclude that most of them are not really relevant. And you'll wind up with, in this case, 21 studies that were described in 22 publications. So the yield is obviously not very big, but that's something that we basically encounter every time. Well, it's one thing to find the studies and the publications. It's another thing to determine whether or not they're any good. And that's why you have a step in which you assess the quality of these publications using a standard kind of a methodology. And you can see by means of the happy faces a way in which the quality of the individual studies are documented. And you can see on the left-hand side, I don't know if you can see it on your screen, but with patient selection, that's one of the sort of the weakest aspects of these kinds of studies. Basically, not knowing for sure where these people come from and how they were selected, because it's typically not well documented in the papers describing the results. So the focus might be on the results, but you really want to know where these people came from and whether they were, how they were selected. And then comes the more analytical part, the quantitative part. And I want to sort of describe to you what we mean here when I'm going to use the terms sensitivity and specificity. Now, in the case of this, third application of contrast-enhanced ultrasound, sensitivity refers to the probability of a positive test if there's a malignancy. And the specificity refers to the probability of a negative test if there's, no malignancy. So in both cases, you want 100%, you want to score 100% like many other things, 100% sensitivity and 100% specificity. Now, having said that, I can then now show you the results that we found in the meta-analysis from the results from the literature. And you can see on the left-hand side, upper left-hand side, basically that we first looked at contrast-enhanced ultrasound. The upper part of the screen and the lower part of the screen just shows us the results of the contrast-enhanced CT. And what you can see then is basically an overall score of 95.1% for sensitivity of contrast-enhanced ultrasound compared to 94.6. So a slight difference, but obviously slightly in favor of contrast-enhanced ultrasound. And on the right-hand side, you see the results for specificity, right? Again, 100% is what you want. You see pretty high scores here, 93.8% versus 93.1%. And here again, contrast-enhanced ultrasound scored a little higher. What we typically do in these kinds of studies is we try to arrange it in such a way that you have a decision tree of some sort. Basically, shows us the two different options that are available. And here again, we basically had two comparisons that we made: contrast-enhanced ultrasound versus contrast-enhanced CT, and an additional analyses versus contrast-enhanced MRI. And on the right-hand side, as I say, the usual suspects, if you will, they basically were looking at the costs in every single case, but the effects in this case relate to life expectancy and quality-adjusted life expectancy. Why life expectancy? Basically because in these kinds of analyses, we don't want to look at the short-term benefits. We want to include the long-term benefits, because sometimes the benefits don't appear immediately. They appear much later. So that's why you can see this term of life years, and just keep in mind that in this case, we're talking about life expectancy. As I said before, though, with a test, it doesn't magically yield any benefits. The question is, what happens between the time in which you do the test and the time when you can see what the cost and effects will be. And in this particular case, as you probably know, there are many different kinds of disorders that could be diagnosed when you use this kind of a test. And the question is, what kinds of options do we see? And here, when it comes to, this is basically sort of diagnostic test assessment methodology, that you have 4 different kinds of options. With a positive test, you can have a true positive or false positive test. With a negative test, you can have a false negative or a true negative test. So in this case, as I showed you before, the positive test means that this person could be labeled as having a malignant lesion. And with a negative test, this person could be labeled as having benign, but in many cases, that's not necessarily true. So with the true positive, of course, that's exactly what you're hoping for. False negatives, that's the kind of mistake you don't want to make. And in this case, you have to think, okay, if these things can happen, how would this person perhaps be treated after this test result? So in the case of the true positives, you basically would be treating the person as you would hope to treat the person. And then we had to include in our analysis what kinds of treatment that would entail. So depending on the actual diagnosis, of course, then you have the different appropriate treatments. And then with the false positives, basically the question was, how would this kind of mistake, this kind of error be detected? And what we basically had to assume was, in certain situations, it will be detected sooner or later. But the question is, when will it be detected, and what kind of treatment option would have occurred by then? Either way, though, with these false positive errors, you're talking about unnecessary treatment, and which means unnecessary costs, and maybe, obviously inconvenience for the patient, and perhaps stress for the patient. The patient hears something which is actually not true. And then with the negative test results, here you have the false negative and the true negative. So true negative, that's a correct result. The patient it doesn't require any follow-up usually, but the real issue lies with the false negative results. That's basically a different kind of error, which would mean some delay in necessary treatment, which would probably lead to some kind of health loss, and possibly even extra costs because of the delayed treatment. So obviously then with this kind of approach in mind, we basically have these two kinds of models, one for contrast-enhanced ultrasound, one for contrast-enhanced CT that we included in our analysis. The other thing we needed to include, of course, were the costs. How much do the different parameters or the elements cost? And here I'm just showing you the kinds of costs that we could include in our analyses. And here up front, you see, or above, you'll see that the cost of diagnostic tests, and down below you see the much higher costs of the different disorders, whether they were correctly or incorrectly diagnosed. What were the results? Life expectancy was 17 years. Quality adjusted life expectancies were the lower, as you can imagine, but you can see that the differences are very, very small, right? Essentially, really, really small. And I'll say it now is that it's because the diagnostic accuracy of the two doesn't really differ that much. If you look at the cost, though, you'll see a slight difference in costs, right? Of 470 pound versus 522 pound, which leads to a difference of minus 52 pounds of cost savings, is what you can say. And again, with a very, very small difference in qualities, we would refer to this as being a situation of dominance, basically a win-win situation. You save money and you basically can achieve the same health outcomes. So that's something that would be desirable for both patients, doctors, but as for the payers as well. What about the additional analyses? Well, we changed many, many different things, but basically whatever we did, it had no effect on the incremental costs or the differences in costs and effects between the two different methods. Obviously, the one factor that did have a role was changing the cost of the tests, because that's something that would be incurred every single time. So the important factor here was the diagnostic accuracies of the test. If they're very, very similar, then there's not too much you can expect downstream. So my main message is, as I said, these kinds of cost effects analyses represent an important criterion in use that's used by policymakers regarding reimbursement implementation decisions. And these kinds of analyses require a variety of different kinds of factors, estimates of diagnostic accuracy, many different assumptions that we have to test. But based on these analyses, we concluded that the contrast-enhanced ultrasound for the characterization of instantly detected focal liver lesions is cost-effective. Thank you.
Thank you very much, Professor Redekop.